We continue our lecture on interventional radiology. One of the main procedures which are taken is called embolization. Embolization, and it is a therapeutic procedure. Why we do embolization? We have a bleeding to stop it, so we embolize the vessel that causes the bleeding. We have an aneurysm, either it's a bleeding aneurysm or we afraid from a risk of rupture, or it's a growing aneurysm causing problem for the patient, especially in the brain. So we embolize it to stop this risk. Or sometimes we embolize the feeding vessel of a tumor, especially in case of advanced tumors or in liver hepatocellular carcinomas. This is a case of advanced bladder tumor, multifocal. You can see this is bladder, this tumor inside. So this case beyond surgery. This is pre-embolization. You can see the internal iliac vessels. This common iliac, this external, and this the internal iliac, which is the supplier for the bladder and the tumor inside the bladder. This is the other one. So what we do, we can embolize this artery usually by putting embolic material, which is coil, inside the vessel lumen. Like this is the coil inside, so you can see this cut, so no more blood flowing to the branches of the internal iliac and to the tumor. So this will either stop the bleeding or decrease dramatically, which is a palliative measure in such advanced case. Of course, this can be used also in pelvic trauma when there is a lot of bleeding and uncontrollable. So this is another case. You can see it's a CT abdomen. Case of trauma, you can see a large liver hematoma. We did angiography, diagnostic angiography. This is a catheter going to the celiac artery, then to the common hepatic artery to visualize where the bleeding point. So you can see here there's an aneurysm, which is the source of the bleeding. So what we have to do is to go further down to the bleeding point to save and not embolize the normal vessels, of course. So after the embolization, you can see this is our catheter, and this is going to the bleeding branch, and multiple coils put inside this vessel to obliterate it, so no more aneurysm visible and no more bleeding. And the rest of the liver arteries are preserved. So we could stop bleeding by this without operation. Another case is the cerebral angiography. This is internal carotid artery and its branch, middle anterior, and other cerebral arteries. We can see a very large, ugly aneurysm, which is usually we cannot operate on it. So here we can see post-procedure, it is almost there's no more aneurysm and the vessels are all spared. So you can see this coil inside the aneurysm. So it's obliterated almost completely. And there are a lot of indication for embolization in the brain, IV malformations and aneurysms. This is another case. You can see this CT brain, native scan, subarachnoid hemorrhage, bilaterally interhemispheric. And this is a CT angiography 3D reconstruction. You can see this internal carotid becoming cerebral, and this is the aneurysm. And it is a outpouching from the vessel. So here you can preserve the vessel. You can put some coil inside to obliterate this lumen without obliterating the normal vessel, because you need blood flow to the other part of the brain. All you need to obliterate the aneurysm lumen without obliterating the vessel. Here is a digital subtraction angiography. You can see in the anterior cerebral artery, this is the aneurysm outpouching to anterior inferior part from this portion, which is close to the union with the other internal cerebral artery, which is a common site for aneurysm. You can see after coil embolization, there's no more aneurysm, but the vessel is preserved. This is ideal treatment to obliterate the aneurysm lumen without hurting or damaging the normal vessel or preserving the flow into the vessel. We have a lot of cases which we do biopsy and range of any collection, including hemorrhage, pus, seroma, or other collections. These all can be done percutaneously, and it's a simple procedure. The simplest one is called FNA, fine needle aspiration. We go to the target, for example, if you have a mass, for example, inside the liver, percutaneously through a very fine needle, usually 21, 22 gauge, we can go into the mass and aspirate some cells for cytology. This is called FNA, fine needle aspiration. We put it on a slide, we fix it and send it to histopathology. Sometimes we need, or better, if you get a bigger section of this mass. So what we do, we can do what's called true cut needle biopsy. So you get a fine thread of tissue from the mass or from that organ. Of course, we need a bigger needle with special technique to cut the tissue. So the needle is called true cut biopsy needle. We can cut a very thin, usually 1 millimeter thick, about 2 centimeters long thread of tissue from that pathology or organ. We can do histopathology examination. It's better for diagnosis of tumor, of course, than FNA. Drainage of abscess or collections, the principle is the same. So ginger, if we have a collection here, for example, contain pus, the skin, we can put a needle there. The tip of the needle should be inside the collection. This is Soldinger technique. Then we put a guide wire through the needle here. Then we can remove the needle and we can do dilatation of this tract by dilators and put finally to put a pigtail catheter to drain this collection. This is an example of prostate biopsy, which is better to be done under ultrasound guide transrectally because you can guide the biopsy needle to the exact location. For example, this is the prostate, usually the tumor in the peripheral zone. So our guide, our needle will go from here. You can see this is the needle. This is our path. So you can see here the needle is white line. Different areas we can guide the needle and take multiple biopsy from this prostate. So any mass or any lesion, we can guide it by ultrasound or CT to take biopsy from it. This is another case of truncal biopsy CT guided. This is the patient is prone, and this is a para-aortic mass, mostly a lymph node. You can see this is aorta and this is the mass. So we put the patient on prone and we enter from here. You can see under the guide of CT, this is our needle going through paravertebral muscles along paravertebral region directly to the mass and taking the biopsy. This is another case of drainage of an abscess under CT guide. You can see here this pelvic CT scan. We have a large collection pus with some gas bubbles inside. So we can do a needle here, dilate the tract, then we can put a pigtail catheter. Here our pigtail catheter is inside. Through this pigtail we can drain the pus. This is another case, CT scan of upper abdomen. You can see a very large fluid collection in the region of pancreas, usually this pancreatic pseudocyst or abscess. So we can guide our needle by the CT, then we put a guide wire, then dilate, then put in a pigtail catheter. So finally, put in a pigtail catheter with drain of the fluid. So you can see there's no more, almost all the fluid is drained through this catheter. We have another procedure which is done by radiologists. It's called transjugular intrahepatic portosystemic shunt or TIPS. It's done percutaneously. We do create a communication channel between the portal and hepatic venous system. You know, in portal hypertension, there is resistance of flow from the portal vein toward the hepatic veins. So the patient portal venous pressure will increase, and this will cause a lot of problems to the patient, especially ascites, which sometimes it is irresistant. In that case, we can do what's called portosystemic shunt. We do a shunt between the portal vein to the hepatic vein to bypass the portal venules. Sometimes in case of recurrent variceal bleeding, which are not controllable by sclerotherapy or other endoscopic banding. This is the case of TIPS. This is the portal vein. This splenic mesenteric become portal. This is the inferior vena cava. So what we do is to go through inferior vena cava, penetrate the liver to the portal vein, making a channel, dilate the channel, put a stent. We put a stent between the one end in the portal vein, the other end in the inferior vena cava, like this one. One end in the portal vein, the other one in the inferior vena cava. So the blood from the spleen and GIT will directly go to the portal vein without bypassing the liver to the inferior vena cava to settle these varices. This is before, this is after. You can see before there are a lot of varices in the gastric and esophageal region, which cause bleeding. So after decompression of this and opening of this channel, you can see there's no more varices. They all collapse. Another way, which is called PTC or PTBD, is percutaneous biliary drainage. Same procedure. Through a needle, we go to the bile duct percutaneously. We do dilatation either by balloon or dilator. We can drain the bile externally, or we can manage internal drainage by opening any structure, dilating it, and putting a stent, which is called internal drainage. So how it is done is same by Sardinia technique. You put a needle into the bile duct, which are usually dilated because of obstruction, under ultrasound guide and fluoroscopic guide. Then you put a guide wire into the bile duct. You put a sheath. Then you try to bypass this stricture. This is a stricture, usually cholangiocarcinoma or other tumors, secondaries, sometimes benign, postoperative, post-traumatic stricture. We bypass the stricture, we dilate it, we put a guide wire, then dilate it, then we can put a stent here to open the stricture. In kidney, we have also a lot of intervention. The most common one, probably percutaneous nephrostomy. In case of obstruction, to relieve the obstruction, we put a pigtail catheter inside the pelvic catheter system to preserve the renal function, because obstruction will cause damage to the kidney and it may cause pyelonephrosis, which further damages the kidney. So drainage sometimes is essential until you relieve the obstruction. So we can do under ultrasound. Sometimes we may need fluoroscopy. It's same principle, transition technique. We put a needle into the pelvic system, tip of the needle. We put through the needle a guide wire, usually J-shape. We remove the needle, then dilate the tract by what's called dilators. Then we can put the pigtail catheter and remove the guide wire. So like this case, this is the pigtail catheter. Here you can see this is a pigtail inside the pelvic system. We did antegrade pyelography to see the pelvic system and ureter and downward. So we can do diagnostic and also therapeutic drainage. Drainage of abscess and fluid collection, as we said, can be done almost anywhere. Same principle, even in chest. We can do subgingival technique and put a catheter and drain the fluid. So most of the abscess drainage is replaced by percutaneous drainage. No more surgery unless we cannot do it by percutaneously. There are a lot of other procedures, and almost every day they are growing, more advancing, and more procedures done by interventional radiologists. And that's the end.